Has there been anything at this ASH meeting in terms of the science of mantle cell lymphoma that's helped you think about who might benefit in any ways from any particular types of therapies?
I think that the important question is why the patient failed this type of
Right,
treatment.
sure.
And I think that we can learn a lot about the importance of the mutations or other pathways which are not targeted by these new drugs. So, and there is a couple of the presentation which can help understand what we should use in these patients.
Is there anything you'll take away from this meeting that will make you think differently about how you would treat your patients right now, or plan to be treating your patients in your guidelines for the future?
I think that there is still a debate how to use the maintenance treatment. So we have demonstrated that the maintenance, rituximab maintenance, is a significant, plays a significant role in terms of the improvement of the outcome of the elderly. Now we have a data that at least in terms of the event-free survival or progression-free survival, there is a 20% improvement in terms of the progression-free survival for the young patient. This is one thing. The other thing is that we have to learn how to incorporate MRD. So we still are not in the position just to use it in daily clinical practice, but definitely in very near future we have to rely more on MRD. And there is some other information like to use the novel agent, and hopefully the number of the novel agent will increase. So in the US it's a bortezomib, and ibrutinib. In Europe it's a temsirolimus, and ibrutinib hopefully it will be the lenalidomide. So we have to learn how to use these new drugs.
You've talked a little bit about maintenance with antibodies. Do you see a role for some kind of maintenance consolidation with some of these novel agents following chemotherapy, or do you see the future being either chemotherapy or novel agent? You know,
these new drugs are not used as for a certain number of the cycles. It means like 6 or 12 cycles, but it's used until the progression or toxicity. And definitely the exposure to the drug is longer, but at least in my opinion, it plays a role in terms of the improvement of the outcome of these patients. So I think that the maintenance treatment with the new drugs definitely is on the table.
Sure. Has there anything you've seen at this meeting that's kind of surprised you in terms of the field of mantle cell lymphoma?
I would not say to surprise me,
because you knew it all already. Yes.
But I think that it's really great opportunity to see how the step by step the outcome of the patient is improving. So we started with the first line treatment, which is now not satisfactory, but significantly better
than we had before.
We have
Sure.
10 years before, and now we are improving the outcome of the relapse refractory patients. So, and it's very nice to see how we are able to not only to improve by our usual daily practice, but we can incorporate the better understanding how this disease behaves, what is behind, and how we can combine and manage this patient.
And where do you think the whole field is going, trying to project 5 and 10 years ahead in terms of mantle cell lymphoma?
I think definitely. So we have been talking about. So it's the incorporation of the new drugs, the combination of the new drugs,
and hopefully more new drugs to follow.
And hopefully to understand and to define on a personalized way which patient should and can respond to which drug or which combination. But as I already mentioned, so at least from my point of view, for 5 or 10 years, the chemotherapy still will be the backbone for the treatment. But definitely, so there is some subgroups of patients which behave still very poorly on the biological levels, and we have to learn how to manage these patients, or maybe we can not to use this sometimes very intensive treatment for the patients who have a very good prognosis in this moment. So there is still a lot of the questions we have to answer in favor of our patient management.
So what you're hearing is that a lot of new data are giving us new ideas in terms of thinking about how we approach mantle cell lymphoma patients, how we look to continue to see the improvements in overall survival that we've seen over the last few years, new insights into thinking about what are the ways we can start to ask how we can more rationally personalize the medicine for our patients. This remains a very exciting time in the treatment of mantle cell lymphoma, as in all of the B-cell malignancies, and we look forward to next year's meeting.